Med history.
Hemorrhagic fever with renal syndrome is a zoonotic hantavirus infection characterized by thrombohemorrhagic syndrome and predominant kidney damage. Clinical manifestations include acute fever, hemorrhagic rash, bleeding, interstitial nephritis, and in severe cases, acute renal failure. RIF, ELISA, RIA, and PCR belong to specific laboratory methods for the diagnosis of hemorrhagic fever with renal syndrome. Treatment consists in the administration of specific immunoglobulin, interferon preparations, detoxification and symptomatic therapy, hemodialysis. The definition of HFRS as a viral disease was proposed by the Soviet bacteriologist, virologist, and immunologist A. A. Smorodintsov in 1944. The virus itself was isolated from animals by South Korean scientist N. W. Lee in 1976 and from humans in 1978. Viral particles are rounded formations with a diameter of 90 to 130 nanometers. They have a lipid shell with protrusions, glycoprotein spikes, and contain single-stranded RNA. The following are encoded by the genome: RNA-dependent RNA polymerase, nucleocapsid protein N, surface glycoproteins GNGC. Depending on the type of virus, there are different numbers of open reading frames encoding non-structural proteins. The virus enters the host cell by attaching to its surface with the help of specific G proteins. The high-risk group for the incidence of hemorrhagic fever with renal syndrome includes agricultural and industrial workers, tractor drivers, and drivers who are actively in contact with environmental objects. The incidence of human diseases directly depends on the number of infected rodents in a given area. GLPS is recorded mainly in the form of sporadic cases, less often in the form of local epidemic outbreaks. After an infection, persistent lifelong immunity remains. Cases of repeated morbidity are rare. Pathogenesis. The pathogenetic essence of hemorrhagic fever with renal syndrome is necrotizing panvasculitis, DIC syndrome, and acute renal failure. After infection, the primary replication of the virus occurs in the vascular endothelium and epithelial cells of internal organs. The accumulation of viruses is followed by viremia and generalization of infection, which are clinically manifested by general toxic symptoms. In the pathogenesis of hemorrhagic fever with renal syndrome, an important role is played by autoantibodies, autoantigens, CIC, which have a capillary-toxic effect, causing damage to the walls of blood vessels, impaired blood clotting, the development of thrombohemorrhagic syndrome with damage to the kidneys and other parenchymal organs, liver, pancreas, adrenal glands, myocardium, and the central nervous system. Renal syndrome is characterized by massive proteinuria, oligoanuria, azotemia, and CBS disorder. An interesting fact is that mutations of hantaviruses during replication occur in parallel with the evolutionary changes of their natural carriers, rodents. The resistance of viruses in the external environment is small and depends on the combination of humidity and temperature. At 56 degrees C, they die in 15, 30 minutes, from 0 degrees C to 4 degrees C in 12 hours. In a test tube with blood at 4 degrees C, they persist for about 4-7 days. At room temperature, hantaviruses remain indoors for about 5-9 days. In natural conditions of forests or meadows at an average daytime temperature of 20 degrees C and humidity of 40–60%, the virus persists in the litter for up to 2 weeks. Viruses cannot withstand increased acidity, are quickly inactivated when exposed to acetone, benzene, and chloroform, and die from ultraviolet radiation complications. Specific complications of severe clinical variants of HFRS may include infectious and toxic shock, hemorrhages in parenchymal organs, pulmonary and cerebral edema, bleeding, myocarditis, meningoencephalitis, uremia, etc. When a bacterial infection is attached, pneumonia, pyelonephritis, purulent otitis media, abscesses, phlegmon, sepsis may develop. Mechanisms of virus transmission. Airborne dust. When inhaling particles of dried rodent feces, for example, when cleaning at the cottage, the main route of infection. The virus enters the human lungs, where there are the most favorable conditions for its development. Contact. When infected material from the external environment gets on damaged skin or mucous membranes, as well as when an animal is bitten. Alimentary. When using thermally unprocessed foods infected with the virus, vegetables, root crops. Aqueous. when using unboiled water with viruses trapped in it. Vertical, from the infected mother to the fetus. A person is usually not a source of infection and is not contagious to others. Cases of infection are extremely rare and are observed only in the laboratory. All people are susceptible to the disease, most often men of active age who are associated with certain professions or lifestyles. Farmers, sewage collectors, tractor drivers, foresters, geologists, summer residents, workers of industrial enterprises are ill. Children, women, and the elderly get sick, much less often due to less contact with the sources of the virus in the natural environment and the peculiarities of immunity, if a person has already been in contact with the virus. Seasonality is summer-autumn. Once every 3-4 years, the incidence increases due to the activation of rodents living near humans. Immunity after a disease is persistent, lifelong, type-specific. Recurrent HFRS diseases are usually caused by another type of virus, with the exception of immunosuppressive conditions. In the early days of the disease, Class M antibodies appear, early protective proteins that indicate an acute stage of the process. They can last up to 18 months. After a short time, Class A antibodies appear in the blood, lymph, and saliva. They are also characteristic of the acute period of the disease, but sometimes they are detected even years later, for example, with HFRS caused by the Pumala virus. Also, antibodies of classes E and G are produced in the body, which are an indicator of the formed immunity and persist for life. Symptoms of hemorrhagic fever with renal syndrome. The incubation period ranges from 4 to 49 days. On average, it lasts 2-3 weeks. Its duration depends on the type of pathogen, the dose of the pathogen that has entered the body, the place of penetration, the immunoreactivity of the body, etc. The vast majority of cases occur under the mask of mild and moderate acute respiratory infections, in the form of a short-term acute onset form, and as a rule, are not recognized. Characteristic syndromes: general infectious intoxication, kidney damage, hemorrhagic, lesions of the gastrointestinal tract, hemodynamic disorders, neuroendocrine, lesions of the respiratory tract. The onset of the disease, febrile period, is usually acute. Sometimes there is a slight prodroma in the form of pain, body aches, and an increase in body temperature to 37.5 to 38 degrees C. Fever appears with a rapid increase in the temperature reaction to the maximum figures, 38 to 40 degrees C, which lasts for 5-11 days. Fluctuations in the temperature curve do not have any special features. Patients are concerned about chills, severe headache, aches and pains in muscles and joints, dry mouth and thirst. Weakness, sweating, and adenomia are rapidly increasing. A slight cough may occur. Appearance of patients: hyperemic, reddened, upper half of the body, injected reddish sclera, whites of the eyes, possible spotty enanthema of the soft palate, the appearance of small spots. With the progression of the disease, a petechial rash, small hemorrhages, appears in the trunk area, the inner surface of the shoulders and injection sites. Small nosebleeds are possible. When squeezing tissues and pinching, a hemorrhagic rash appears in these places. Diagnostics. The clinical diagnosis of HFRS is based on the cyclical course of infection and the characteristic change of periods. When collecting an epidemiological history, attention is paid to the patient's stay in an endemic area, possible direct or indirect contact with rodents. When conducting a nonspecific examination, the dynamics of changes in the indicators of general and biochemical analysis of urine, electrolytes, biochemical blood samples, CBS, coagulograms, etc., are taken into account. In order to assess the severity of the course and prognosis of the disease, ultrasound of the kidneys, FGDS, chest X-ray, ECG, etc., are performed. Specific laboratory diagnostics of hemorrhagic fever with renal syndrome is carried out using serological methods: ELISA, RNIF, RIA, in dynamics. Antibodies in the blood serum appear at the end of the first week of the disease, reach their maximum concentration by the end of the second week, and remain in the blood for 5-7 years. The RNA of the virus can be isolated by PCR examination. GLPS is differentiated from leptospirosis, acute glomerulonephritis, pyelonephritis, and enterovirus infection, and other hemorrhagic fevers. Prognosis and prevention. Mild and moderate forms of hemorrhagic fever with renal syndrome in most cases end in recovery. Residual phenomena, post-infectious asthenia, lower back pain, cardiomyopathy, mono and polyneuritis, are observed for a long time in half of those who have been ill. Convalescents require quarterly dispensary supervision by an infectious disease specialist, a nephrologist, and an optometrist throughout the year. Severe course is associated with a high risk of complications. Mortality from HFRS ranges from 7–10%. Prevention of hemorrhagic fever with renal syndrome consists in the destruction of mouse-like rodents and natural foci of infection, prevention of contamination of dwellings, water sources, and food with rodent secretions, deridization of residential and industrial premises. No specific vaccination against HFRS has been developed.